Hello, everyone, and welcome to our module on cardiac embryology. So about 3 weeks after the egg is fertilized, the primitive heart begins to form in the embryo. And one thing to know about the primitive heart is that it forms as a straight tube, like what's shown in my cartoon on the slide here. This tube will eventually fold to form the atria and the ventricle and the valves that you know of in the adult heart. And the parts of the primitive heart tube have various names, so let's go through this now. So this part up here at the top is called the truncus arteriosus. This section in here is the bulbus cordis. You then have this red section, which is called the primitive ventricle. The blue section right here is called the primitive atrium. And then finally, this section at the bottom, including these two horns, is called the sinus venosus. So the different parts of the heart tube will go on to form different structures. So the truncus arteriosus has the word artery in its name, and that's a way that you can remember that it forms big arteries like the aorta and also the pulmonary artery. The bulbus cordis is going to form the smooth portions of the left and right ventricle. We'll talk about what I mean by this in a minute, but within the ventricles, you can find smooth portions that are smooth, like the name implies, and then trabeculated portions, which are more bumpy. The trabeculated portions of the left and right ventricle come from the primitive ventricle, whereas the smooth portions come from the bulbus cordis. And then the primitive atrium will go on to form trabeculated portions of the atria. And then the sinus venosus goes on to form most of the right atrium and the coronary sinus, which, as you may know, is the large vein that drains blood from the myocardium into the right atrium. Let's zoom in a little bit and talk in more detail about the sinus venosus. So it has two horns, as you can see on the slide here, a right horn and a left horn. The left horn will go on to form the coronary sinus, and the right horn will form the smooth portions of the right atrium. These portions of the right atrium are called the sinus venerum. Remember, the trabeculated part of the right atrium comes from the primitive atria, but the smooth part of the right atrium comes from this right horn of the sinus venosus. Just to make this point about trabeculated versus smooth portions of cardiac chambers very clear, let's look at this cartoon on the screen here. So you can see that there are bumpy portions of the right ventricle and left ventricle here. Those are the trabeculated portions of the ventricles. And then near where the right ventricle sends blood out into the pulmonary artery, it's very smooth. And near where the left ventricle sends blood out into the aorta, it's also very smooth. So those are the smooth portions of the ventricles. They're generally found towards the arteries that take blood away from the ventricle chambers. Okay, let's talk about the cardinal veins. So the cardinal veins are structures that develop into the SVC and IVC. The SVC shown here and the IVC shown here do not come from the heart tube. They come from the cardinal veins. These cardinal veins will eventually connect to the right atrium and then go on to form the vena cava. The superior vena cava develops out of the right common cardinal vein and the right anterior cardinal vein, and the inferior vena cava develops from the posterior cardinal veins. Shown on this slide is a cartoon of how the primitive heart folds from about 23 days of development to 35 days. You can see it starts as the heart tube, like I showed before, and then it folds into the final structures here. They're color-coded, so you can see like the blue structures here come from the atrium and the sinus venosus, and the red structures like the ventricles come from the primitive ventricles. And all the things we talked about before are happening here. The different structures in the primitive heart tube are being folded to form the structures in the adult heart. And if you really want to understand how this process occurs, go to YouTube and Google heart folding in the embryo, and you will find a beautiful cartoon video. It's very short, and it shows you exactly how the heart folds to go from the heart tube to the adult heart. Part of this process of the primitive heart tube folding is called cardiac looping. So the heart tube loops at about 4 weeks of gestation, and this part of the process is what establishes the left-right orientation of the heart in the chest. As a result of cardiac looping, that's why you end up with your heart on the left side of your chest. This process of looping depends on cilia, which are modal structures, and also dynin, which are modal proteins, and I talk about both of these things in detail in videos in the cell biology section. But what you should be aware of is that if a person is born with a problem with cilia or dynin, they can develop dextrocardia, where the heart is on the right side of the body. Basically, this looping process doesn't occur normally. And so this is something you can see in Cartagener syndrome, which is a form of primary ciliary dyskinesia that, once again, I talk about in the cell biology section. And this on screen here is an X-ray of a person who has dextrocardia. This is the left side of the body. This is the right side of the body. The heart should be over here, but you can see this is the heart right here over on the right side of the chest. That's evidence of dextrocardia, problem with cardiac looping. While the primitive heart tube is folding and looping, inside the heart tube walls are developing that will eventually separate the right and left ventricles, right and left atria, and also separate the pulmonary artery from the aorta. So now let's talk about how those walls form inside the heart, and we'll start by talking about how the ventricular septum forms. This is the wall that separates the right from the left ventricle. So early in development, you have a structure like what I've shown here in my cartoon. This bottom portion here is going to go on to form the ventricles, and it has a little outgrowth like this, and inside the outgrowth, a wall is forming called the aorticopulmonary septum. This is a wall that's going to eventually separate the aorta from the pulmonary artery. The next thing that happens is a structure develops called the muscular ventricular septum. That's what's shown in blue in my cartoon here. This is going to form the very thick part of the wall that separates the right from the left ventricles. Next, what happens is this aorticopulmonary septum part starts to twist, and it twists to eventually form the aorta and the pulmonary artery. But as it twists, the septum, this wall that's here in the top part of this drawing, is going to connect to the muscular septum. It's going to fuse with the muscular septum. And when it fuses, it creates a small part of the wall between the two ventricles called the membranous septum. That's what's shown in green here. This is a part of the ventricular septum that forms from fusion of the aorticopulmonary septum and the muscular septum. And importantly, this membranous septum is very thin. So as we'll talk about in a minute, it's prone to developing defects. Then what happens is structures called endocardial cushions arise. Those are shown as yellow squares here in my drawing. And they will go on to complete the separation of the right and left atria and the right and left ventricles. If something goes wrong as the ventricular septum is developing, holes can be left behind. Those holes will allow communication between the right and left ventricles, and those holes are called ventricular septal defects or VSDs. The most common type of VSD is a membranous VSD, as I said on the last slide. And that's easy to remember if you know that the membranous septum in the developing embryo is very thin, and therefore it's prone to having holes left behind. Muscular VSDs are less common, and that's easy to remember if you know that the muscular septum is much thicker than the membranous septum in the developing heart. And then finally, there are two very rare forms of VSD, which I've listed here just for completeness sake. I don't think these are very important for you to know about for step 1 of your boards. All right, let's talk in a little bit more detail about those endocardial cushions. Those are the two yellow squares here in my cartoon that separate the right and left atria and finish the separation of the right and left ventricles. So the endocardial cushions contribute to development of a number of structures located at the top of the ventricles right near where blood leaves to go to the pulmonary artery or the aorta. So the endocardial cushions contribute to development of the septum between the atria, the septum between the ventricles, and they also contribute to development of all the valves found in the heart. So when children are born with so-called endocardial cushion defects, they can develop a number of congenital heart problems, including atrial septal defects, which we'll talk about later, ventricular septal defects, and also valvular malformations. And endocardial cushion defects are particularly common in Down syndrome, which I talk about in great detail in a video in the genetics section. Let's talk in a little bit more detail about the development of the aorticopulmonary septum, also sometimes called the spiral septum. This is the wall that's going to separate the aorta from the pulmonary artery. It's super high yield for step 1 of your boards to know that this wall is formed from neural crest cells. I know that sounds crazy because neural crest cells you probably think of as contributing to brain development, but some of those cells migrate to the truncal and bulbar ridges in the primitive heart tube. Those are little bumps that form right around here, and then they go on to form a wall, and that wall is going to separate the aorta from the pulmonary artery. And as we talked about on the last slide, the aorticopulmonary septum also fuses with the interventricular septum, and it forms that membranous septum between the left and right ventricles. If there's abnormal formation of this aorticopulmonary septum, that can lead to a number of different types of congenital pathology. So for example, if this septum doesn't develop normally, you can get transposition of the great vessels. This is what happens when there's failure of the aorticopulmonary septum to spiral. I talked earlier about how it sort of spins around itself or spirals. That's why it's sometimes called the spiral septum. But if that doesn't happen normally, that's how you get transposition. If there's skewed development of the septum and it doesn't develop in the normal spot, that's how you can get tetralogy of flow. And then finally, if it's partially or incompletely developed, that's how you can get a persistent truncus arteriosus. And I talk about all of these congenital heart disorders in detail in another video, but what you want to remember is that they form from problems with development of the aorticopulmonary septum. Okay, now let's talk about how the atrial septum forms. This is the wall that will separate the right atrium from the left atrium. So if you look at my cartoon I've put on the screen here, at the bottom are the future ventricles, and we were just talking about how the ventricular septum forms. And when I was talking about that, I said that there were these structures called endocardial cushions. They develop sort of at the top of the future ventricles and the bottom of the future atria. And they contribute not just to development of part of the ventricular septum, they also contribute to development of the atrial septum, as we'll see in just a minute. So the first thing that happens in development of the atrial septum is a structure called the septum primum forms. That's what I've shown in blue here. This is eventually going to become part of the wall that separates the right from the left ventricle. And it starts growing downward like this. But the tricky thing is, as it's growing downward, some of the cells die from apoptosis. And so eventually what you get is something that looks like what I've shown on the right side of the screen here. You have the septum primum, but it has a gap. And that gap right there is called the ostium secundum. And then there's another gap between the leading edge of the septum primum and the endocardial cushion, and that gap is called the ostium primum. So confusing names here, but the most important thing to know is that the ostium primum is down near the bottom towards the ventricles, and the ostium secundum opens more towards the top or sort of towards the middle of the future right and left atrial chambers. The next thing that happens is the septum primum continues to grow downward, and it's going to fuse with the endocardial cushion, and that's going to be the end of the ostium primum if everything develops normally. That's going to leave behind only one hole connecting the future left atrium over here from the future right atrium over here, and that hole is called the ostium secundum, as we talked about on the last slide. The next thing that happens is another structure forms called the septum secundum. That's what's shown in red here. It's called secundum because it grows secondarily after the septum primum, which is shown in blue. And what that's going to leave behind is a very small opening for blood to move from the right atrium to the left atrium through a structure that we now call the foramen ovale. So this septum primum here is somewhat flexible. It can be pushed in this direction by blood. And when it does that, it allows blood to sneak up and through from the right atrium to the left atrium. And that's going to be the foramen ovale, which is a very important structure in utero because it allows blood to move from the right atrium to the left atrium and bypass the lungs, which are difficult to flow blood through in utero because they're filled with fluid. At the time of birth, the foramen ovale should become obliterated, so there's no longer any communication between the right atrium and the left atrium. But if this doesn't happen, the person will be left with what's known as a patent foramen ovale, or PFO. If you look at my little cartoon on the screen here, what happens at the time of birth is the left atrial pressure rises significantly. And I'll talk about why this happens in just a minute. But when that occurs, it pushes this blue septum primum into the red septum secundum, and the two structures fuse together, and there's no longer a foramen ovale. It turns out, however, that in about 25% of adults, the foramen ovale remains patent. And this is usually of no serious clinical consequence. The majority of people who have a PFO will never have a problem from it, will never become sick from it, but it is present in their adult heart. If you look at this ultrasound image on the screen here, this is the right atrium here, this is the left atrium here, and this is the PFO right here. This is the septum primum right here, this is the septum secundum here, and they haven't come together and fused. So this person whose heart has this echo image is one of the 25% of adults who has a PFO. And what you want to remember for your board exams is that this abnormality is caused by failure of the foramen ovale to close at birth. There's failure of the septum primum and the septum secundum to fuse together. Okay, so I'll finish this video with 3 slides on fetal circulation. So in order to understand how blood moves through the vascular system in the fetus in the womb, the first thing you have to appreciate is that there's very high resistance to blood flow in the lungs. The lungs are filled with amniotic fluid, there's constriction of blood vessels, and it's very difficult for the right ventricle to get blood through the lungs. This isn't a problem for the baby though, because the baby's receiving oxygenated blood from the umbilical veins, which drain the placenta and carry oxygen coming from the mother. Now the blood in the umbilical veins is only about 80% saturated. It's lower than the saturation of our normal arterial blood, and the partial pressure of oxygen is very low at 30 instead of 100 or more, which is what you find in adult arteries. The reason this very low amount of oxygen can generate a relatively high 80% saturation of hemoglobin in the umbilical veins is because the umbilical veins have fetal hemoglobin, which has a very high affinity for oxygen. So once this oxygenated blood from the umbilical veins gets into the fetus, it then travels straight to the right atrium. It bypasses the liver via a structure called the ductus venosus. And it does this because the liver is not very important in the baby when it's developing. Most important metabolic functions of the liver are carried out on the mother's side, and so it's not so important for the baby's liver to do a lot of work. So blood bypasses the liver, and then it gets into the right atrium, but it can move through the foramen ovale over to the left side of the heart, bypassing the lungs. If you look at my cartoon on the screen here, we've got blood from the umbilical vein coming in here from the IVC. It goes to the right atrium, but then it can jump right over to the left side, bypassing the lungs because of the foramen ovale. And remember, it's hard for that blood to move through the lungs because there's high resistance to flow. The path of least resistance is to go through that foramen ovale over to the left side of the heart. Now, even though the foramen ovale is present, some of the blood from the umbilical veins is going to reach the right ventricle, and it's going to get pumped out into the pulmonary arteries. But once again, it's hard for that blood to move through the lungs because of the high resistance to flow. So that blood is going to bypass the lungs through another shunt besides the foramen ovale, and that other shunt is called the ductus arteriosus. It connects the pulmonary artery here to the aorta right here, and it lets more blood bypass the lungs. So we've got two structures, the foramen ovale and the ductus arteriosus, allowing blood to bypass those lungs where there's very high resistance to flow. So all that circulation I described in the last slide is going to continue until the time of birth. And the major physiologic change that occurs in the baby at the time of birth is the pulmonary resistance falls. When the baby's born and starts breathing, all that fluid starts to leave the lungs, and the resistance to flow through the lungs goes way, way down. This allows a gush of blood to go from the right ventricle through the lungs and pour into the left atrium. And this is going to raise the left atrial pressure. And like we talked about a few slides ago, when the left atrial pressure rises at birth and becomes higher than right atrial pressure, it pushes the septum primum and the septum secundum together, and that's going to close the foramen ovale so that it becomes the fossa ovalis. The ductus arteriosus also should close at birth. The reason for this is that in utero, like we talked about before, there's relatively low oxygen tension in the baby's blood, but that oxygen level goes way up at the time of birth when the baby begins to breathe. Also, in utero, there are very high levels of prostaglandins coming from the placenta. But after the baby's born and the placenta goes away, prostaglandin levels fall. So these two changes, rising oxygen tension and lower levels of prostaglandins in the blood, are what trigger the closure of the ductus arteriosus. They cause it to constrict, and eventually it seals off and becomes a ligament. So at the bottom of the screen, I've put a super high yield table that you should know before your step 1 board exam, and it shows the changes that happen from in utero to the time of birth in pulmonary vascular resistance, right atrial pressure, and left atrial pressure. You want to make sure you understand all these things because lots and lots of questions can be generated from these changes. The final physiologic change that occurs at birth that you need to be aware of is that in utero, the placenta causes a low resistance to flow through the body in the baby. In other words, babies in utero have very low SVR, and that's because the placenta is present. Basically, anytime you add another pathway for blood to move from the arterial system to the venous system, you lower the SVR. And so you have this whole extra conduit for blood in the placenta present in the total body, and that lowers the SVR. In utero, this is one of the things that helps keep the left atrial pressure low. It's so easy to move blood out of the left ventricle in utero that the left atrium is always being drained of blood and the pressure is very low. But at birth, when you take away the placenta, there's a sudden increase in peripheral resistance, and it's very high yield to understand this physiologic change that occurs at the time of birth. This is going to do a couple of things. First of all, there's a rise in the systemic blood pressure in the baby. There's a rise in the left ventricular pressure, and there's also a rise in the left atrial pressure. All of these things come from the increase in peripheral resistance when the placenta goes away at the time of birth. So now if you look at the bottom of the screen, I've added to the chart from the last slide the systemic vascular resistance. That goes from low in utero due to the placenta being present to high after birth due to the placenta going away. Once again, these changes right here are super high yield for you to understand for your step 1 exam. And that concludes our module on cardiac embryology.